afternoon, and welcome to the 18th International Symposium on Ischemic Heart Disease and Acute Cardiovascular Care. My name is Héctor Bueno. I'm a cardiologist based in Madrid. My co-chair is Antonio Fernández-Ortiz from Hospital Clínico in Madrid. And we're privileged to open this symposium with, I would say, a master session, which is based on controversies on clinical trials. You know that, clinical trials are the cornerstones of the cornerstone of clinical science development. We use them to change our practice and sometimes to change the concepts that drive our practice. And however, though these, several of these are published in the best journals, New England Journal, JAMA, and so on, European Heart Journal, there's a lot of methodological issues that sometimes we tend to believe because they're published in great journals that they are completely true. Today we're going to have a critical view, an approach of these, and for that we have two, I would say, and I'm not falling short, I'm sure, of the best specialists in the world in the development and analysis of clinical trials. The first one is Stuart Pocock. He's a statistician from the London Hygiene Health University in London. He's definitely, I would say, one of the most renowned specialists in statistics, and he's been serving for several clinical studies and several randomized trials. And Bernard Gersh is a clinical cardiologist. He's been based in the Mayo Clinic for several years. I would say he's probably one of the most, if not the most, universal cardiologist. I wouldn't say he's actually not American. He's South African. He's for several places. He's a good friend from here in Spain. And I think both of them share some of the characteristics why they're here today. They're really long experience, they're really wise, and they have a really critical and personal thinking. And that's why we're gonna, I think, enjoy very much their view on what is the actual research in clinical cardiologists, and that personal views, I think, will gonna be very helpful for us who are the ones who read these trials. So the first one would be Stuart. We would talk about lessons from a trialist, a critique on some recent cardiology trials. Stuart, please.
Right. Thank you, Hector, for that kind introduction to us both. And I hope I can entertain you. Don't be fooled by I've now lost the point. Oh, here it is. By the fact that my title is in Spanish, that's not going to last long. But just to have some Spanish credentials, I thought I'd offer this slide. I was interviewed by El País, and I said, what can I say to them? And it's here, mi trabajo es frenar el optimismo de los científicos. My aim is to stop you getting excited about anything. And I'll try and explain why in the examples I'm going to give you. So first, let me give you, I'm going to critique 6 trials. First, I'm going to concentrate on the most recent from the ACC, Odyssey, VEST, and Secure PCI. And in fact, I've just had accepted an article in JACC, which will actually publish, critique 7 trials presented at ACC from my statistical perspective. In addition, I'm going to critique 3 more trials, Compass Orbiter and TRUE-AHF, which were published in the last year or so. So 6 trials, so let me get on with it. Odyssey Outcomes Trial, a huge trial, alirocumab, a PCSK9 inhibitor, versus placebo in 18,000 acute coronary syndrome patients. They all were maintained on high-dose statin, but still their LDL cholesterol was a little bit elevated. And so we know already that these are powerful drugs, and it reduces LDL cholesterol typically by about 60%. So dramatic effect on lipids. The trial had the composite primary outcome as coronary heart disease death, MI, myocardial infarction, ischemic stroke, and unstable angina. And they had a median 2.8 years follow-up. So this provoked a lot of interest. I think it was the trial that was most captivating at ACC this time, except for the barbershop one, which I'm not covering. I'm sorry to disappoint people on that. And these are the results from Odyssey. We see that the treatment difference in the primary MACE endpoint was substantial. So a hazard ratio of 0.85, 15% reduction, a highly significant result. Note, however, that it takes a year to kick in, the effect. So the first year there seems no difference as regards the effect of the active drug versus placebo. Then we look down to the details. When you have a composite primary endpoint, it's always important to look at the details. And we see here the 4 components, and we see that there was no significant effect on coronary heart disease death, though it is trending in the right direction. But for the rest, non-fatal MI, ischemic stroke, and unstable angina, we see there were significant reductions in these relevant outcomes. I think it's also relevant to say what matters from a patient perspective is the absolute reduction in the first MACE event. So we point out there's 5.62 events are prevented per 1,000 patient years by giving alirocumab rather than placebo. And there's quite a range around that, from 2.35 to 8.89 per 1,000 patient years. Or you can express that as a number needed to treat. So to prevent one patient having a MACE event, you'd have to treat 63 for the average 2.8 years that was done in the trial. So both are useful expressions of absolute risk, which I think we need to do more. But note again, as I said earlier, there's no apparent benefit in the first 12 months. Secondary endpoints, we then want to explore details, and this shows the secondary endpoints in order of their hierarchical testing, we should say. And so we worked our way down. CHD event, if that's significant, which it was, then you can go to the second endpoint, major CHD event, and so on. The hierarchy stops when you get to CHD death, whereas we've already seen there was no significant difference. So in the hierarchical testing spirit of controlling type 1 error, therefore, when you get to the 7th point, which is all-cause death, which in an exploratory way is significant at 0.026, you have to put the little tick of success in brackets because you didn't stay within the hierarchy all the way down. So all-cause death is not formally significant in a technical control of type 1 error sense. It's an exploratory finding. Also worth noting, was this really believable, this all-cause death phenomenon? But we saw that in the Fourier trial, a different patient population, but the same class of drug, evolocumab, there was no mortality signal in the Fourier trial. So 2 reasons for perhaps doubting this all-cause death finding in Odyssey. They then went to, so to speak, try harder by looking at subgroups. And alirocumab, it was proposed, appeared more effective if the LDL was a bit higher at baseline, was above 100 milligrams per deciliter. Then you got a 24% reduction in MACE, which is a bit bigger than what was seen before, and a 29% reduction in all-cause death. But steady on here. This is a bit of positive spin, a tendency to exaggerate by picking a subgroup. Because there was no significant interactions by LDL cholesterol for both MACE and mortality. They were not formally significant. So such positive spin of enhancing the overall claim by selecting a subgroup needs to be a little bit careful in doing that. More plausible is that the absolute benefit, which is what really matters for MACE, is greater in higher risk patients. And I would encourage the authors of Odyssey and subsequent publications to look at that. You need to probably more stratify patients by their overall risk, not just their LDL cholesterol, and concentrate, are there higher risk patients where the absolute benefit is greater and hence affordable with modern day health systems, and that is the way I would go forward with Odyssey at this point. So that's the first trial. The second one, which provoked a lot of interest, is called the VEST trial, and this was to do with a wearable cardioverter defibrillator, which I'll call WCD for short, and it's in high-risk post-myocardial infarction patients with reduced ejection fraction. The trial randomized patients in a 2-to-1 ratio to the active wearing the vest versus control, just being observed, and the primary outcome was sudden cardiac death within 3 months. Secondary outcomes, several of them, included total mortality. So how did this one come out? The results are shown on this slide, and you can see that the primary endpoint, sudden death, there were 1.6% on the vest arm and 2.4% on control, so in the right direction, but nowhere near formal statistical significance. You work your way down the secondary endpoints, and you see, oh, stroke, that's interesting, but it's 0 deaths versus 4, so rather small numbers. And then you get to all-cause death, which is 3.1% versus 4.9%, which is, at least in the use of a p-value, gives you a p-value under 0.05, which some people find exciting. Do I? That's the point. So let's go to the next slide and look at all-cause death. Therefore, you know, people want to have something positive to say. They couldn't do it on sudden death, therefore the focus was on all-cause death. This shows the Kaplan-Meier plot, looking better for WCD. There's a lot of random noise going on here. The numbers of deaths are not that great, and therefore, though it is an observed 35.5% risk reduction, the confidence interval around that is from almost 0 to a phenomenally unbelievable risk reduction. So one needs to be a little bit wary on the interpretation of this slide. So how do I interpret VEST? I can take 2 stances, or you can. You can be the realist or pessimist and say the VEST trial was negative. Negative in the sense that the primary endpoint failed, so to speak. There's no significant reduction in sudden death. Though the observed reduction is 32.8%, but it happens to have a phenomenally wide confidence interval around it. So that's the realist-pessimist approach. The optimist, sometimes called the cheat, says the VEST trial was positive. There was around a 35.5% reduction in all-cause death, but with a confidence interval very wide, as I just said earlier. Now, this is a very fragile p-value. If you just had 1 less death in the control group, then the p-value becomes non-significant. It goes above 0.05. So it's like a significance hanging on a knife edge. And therefore, I think it's best not to call the trial negative or positive, but just saying there are trends of interesting data, but overall, the trial has to be determined as inconclusive, which is sad in a way because these trials are very difficult to do. To get patients to wear this vest, recruitment's very slow, agreeing to be randomized, agreeing to comply with it over a 3-month period, had lots of difficulties. So, but sadly, I think the word inconclusive is in fact probably the best one can do at this moment. There is this unreasonable desire to document all trials as either negative or positive, based on the primary endpoint P being above or below 0.05. But we know P of 0.04 is not strong evidence, and a P of 0.06 is not necessarily a no-hoper. But it must be said that the primary endpoint P being above 0.05 is not a good start to declaring that your trial is positive. What really need is strong evidence. A P of 0.001, something like the Odyssey trial is saying this is a positive trial. I think you're allowed to say that about Odyssey. Then you have proof beyond reasonable doubt, fit to change clinical practice if only you could afford the drug. A p-value, by the way, is no substitute for a brain, so I think it's worth thinking. Right, so that's the second example. Now, the third one presented at ACC that I'm going to critique is the secure PCI trial. Here we're looking at a loading dose of atorvastatin prior to planned PCI. Reasonably substantial trial, over 4,000 ACS patients, undergoing an angiogram with the intention that they will proceed to PCI. And patients were randomized to the 280 milligram atorvastatin loading doses versus placebo, while everyone was getting atorvastatin 40 milligrams daily subsequently. The primary 30-day composite outcome was death, MI, stroke, and unplanned revascularization, a fairly typical composite in this scenario. Now, secure PCI, the primary results were disappointing. There was a slight tendency to fewer MACE events in the atorvastatin arm, the loading dose atorvastatin arm. Remember, everyone got a background atorva subsequently. But the hazard ratio of 0.88 with a wide confidence interval, so not statistically significant. Again, all hazard ratios below 1, but none of them reached significance. And stent thrombosis, 7 versus 15, looks interesting, but again, doesn't reach statistical significance. So insufficient evidence of efficacy. The cumulative incidence of the primary MACE event is here, and you can see, you know, it's really is always looking a little bit better on atorvastatin loading doses, but not enough to get to assertion of a real therapeutic benefit. Disappointed? You're disappointed in your trial? Aha, try subgroup analysis. Can we rescue it? That seems to be what's going on. This is the subgroup analysis that they focused on. It's on cumulative incidence of the MACE event separately for those who got PCI and those who didn't get PCI. So you need to compare the two continuous lines to be looking at patients who did get a PCI. And you can see the atorvastatin arm in orange looks distinctly lower than the placebo arm, and indeed the hazard ratio 0.72 is statistically significant. Similarly, in the no PCI patients, which are about a third of patients never got to get a PCI, they either had medical treatment or cabbage instead, and there you can see perversely it's going in the opposite direction, but not significantly so. Do you believe that? Maybe. Some would say if you believe that, you believe anything, but that's my caution on subgroup analysis. So this shows it a little bit further. But what we're showing is that indeed there is a significant interaction whereby the treatment benefit for those who got PCI did seem better for atorvastatin than those who didn't. If you further break it down by STEMI and NSTEMI, you can get a double subgroup sort of breakdown, and it looks like if you're a STEMI patient, then atorva in the context of PCI look good, and the interaction test is still borderline significant. But we have a problem here in interpretation. Conclusions re-secure PCI, I think, rest on the overall result, that atorvastatin loading doses appear to have no overall effect. There's some evidence of effect in those getting PCI, but we need to beware of this for two reasons. Firstly, it's a post hoc emphasis on the most positive subgroup in the trial, which one needs to be cautious about. Secondly, PCI is what we call an improper subgroup. You shouldn't really be doing the analysis at all, because whether you got PCI or not is not known at the time of randomization, at the time of starting the atorvastatin. And therefore, it's of little practical value because you'd have to be guessing who's going to get PCI and who's not in order to extrapolate the subgroup finding. So I think this requires a cautious interpretation that overall the trial was neutral. Now, I'll leave ACC and go to some other trials published in the last year or so. The COMPASS trial was in over 27,000 patients with stable cardiovascular disease. And this is an interesting three-arm trial where the control is standard low-dose aspirin. An alternative was to get rivaroxaban on a lowish dose. And the third arm was to give rivaroxaban at half the low dose plus the aspirin. So combination, riva, or aspirin. The primary outcome was composite of death, myocardial infarction, or stroke. And this is an interesting trial because it stopped early for superiority of the combination arm. I'll devote riva by R and aspirin by A for simplicity. And they stopped after a mean follow-up of 23 months. And so let's look at the primary findings for the trial as published in the New England Journal. We see that the primary outcome, CV death, MI, or stroke, there's the combination versus aspirin alone is very highly significant, which led to the reason to stop the trial. But note that it seemed to apply in the same direction for the components. So CV death, stroke, and MI all showed benefits in the same direction. Not quite significant for MI, but still trending the same way. Major bleeding, though, there was an excess. And so we have an interesting trade-off. If you do your subtractions here, we are preventing 117 primary outcomes by giving the combination. We are causing 118 major bleeds by giving the combination. So that's a tough trade-off as to whether there is really an important benefit going on here. And that perhaps that trade-off makes it difficult when you stop a trial to come up with what your final conclusion should be. So this shows the sequence of events. For the primary efficacy outcome, at the time of an interim analysis in February of last year, they were showing that they had a highly significant treatment difference, 4.6 standard errors for the combination versus aspirin alone. At that time, Riva alone was also doing better than aspirin alone at a borderline significance, a p-value of 0.015. Now, when you stop a trial, it's not that's the data. There's sort of tidying up and more follow-up is captured in the final database. So there's additional data that comes in. So by the time the trial was published in the New England Journal 6 months later, you're seeing that the treatment difference has reduced a little bit. It's now 4.1 standard errors, still very, very highly significant for the combination. But Riva alone versus aspirin alone is no longer formally significant, still trending in the right direction. So when you stop a trial early and then you get the final results, there's often some regression to the truth, which I think is an example we're seeing here. So issues affecting such a trial as stopping early, the extreme boundary, which was a p-value less than 0.0001 for stopping, means the superiority of the combination for the primary endpoint is highly believable. Not much doubt about that. But there may be a bit of an exaggeration due to stopping the trial on a random high. So it might be believable, but possibly slightly exaggerated. The mean follow-up is then restricted to 23 months, so you don't get the original follow-up you might have liked to have had for a long-term therapy. So we have less assurance about long-term benefit. And we also have less data to make the balancing act between the efficacy and the safety problem of major bleeding. And how this will pan out with the regulators and the FDA and the EMA will be interesting to see what they make of it all. There's another problem of multiple testing here, which is we had 3 issues. There were interim analyses, you had 3 treatment arms, and you have a hierarchy of primary and several secondary endpoints. And as you work through the process of the secondary endpoints, you did see a significant effect on all-cause death, hazard ratio of 0.82 with a p-value of 0.01, but due to the corrections of multiple testing, to really make a claim with the regulator about all-cause death, you really needed the p-value for that less than 0.0025. It does, for you, those of you not enjoying p-values, you might say, oh dear, all these regulatory constraints, all those statisticians at the FDA not allowing us to do what we want, versus common sense, all-cause death matters, can't we believe this? That's the balance of how we interpret this kind of evidence. Now, the Orbiter trial. This was presented at TCT, the Interventional Cardiology Conference in the States last October, and provoked a lot of interest. It was then published in The Lancet at the same time. Is PCI versus a sham control in a small trial, 200 patients with stable single-vessel coronary disease. The primary endpoint for the trial was a change in exercise time over 6 weeks. The procedure, what was actually done, did the patient get PCI or was the interventionist just pretending to do PCI? That was only known by the interventionist. The patient was busy with headphones in listening to music, unaware of whatever was being said, and the assessors were also kept blind. So the Orbiter trial results were that they actually showed that the PCI arm started better than the sham arm. So they had an advantage in exercise time at baseline, which means there was less scope to improve. Nevertheless, they did show a bigger estimate of improvement, and the difference in means was a p-value of 0.2. So this means it was not a significant difference. So PCI, they claim, did not increase exercise time by more than placebo. A rather controversial editorial said this is the last nail in the coffin for PCI in stable angina, which is the sort of silly title you occasionally get in the Lancet. Not really believable. And so the statistical problem was that they were unbalanced at baseline. And if you correct for the baseline imbalance in exercise time, then the adjusted mean difference is 22 seconds, and it's getting nearer to a borderline significance. So the conclusions of this trial, I think, at the moment, need to be cautious. A more valid analysis made the results more positive, but is not published, actually. I got that through the grapevine. It's a small pilot study with a risk of a type 2 error. And 30% of patients didn't really have ischemia anyway, so perhaps should not have been in the trial. And I think there's a need for a larger, better trial with a sham procedure, which it would be very interesting to see done in the near future if it could be, collaborations could be found to do it. I'll skip the last trial because I think we're getting a little short of time, if that's correct. Yeah. So my take-home messages are about these 5 trials that I have critiqued. Odyssey, the absolute MACE benefit is what matters, and beware of subgroup claim and apparent mortality reduction, which are, I think, a little over the top. The VEST trial, the wearable defibrillator, inconclusive regarding sudden death. The trial was underpowered, so the claim on all-cause death is not really quite convincing. Secure PCI, insufficient evidence of efficacy, and we need to beware of subgroup claims regarding PCI patients in that trial. The COMPASS trial, positive trial, but it stopped early, and so efficacy and the trade-off between efficacy and safety really needs more exploration. And the Orbiter trial, small, innovative trials, are exciting, but require, obviously, a cautious interpretation. As you expect from a statistician, I've now used the word cautious rather a lot, so that's me, and I'd better stop there. Thank you very much.
Thank you, Stuart. So we're going to have a discussion together at the end if we have time. So next speaker is going to be Bernard Gersh. He's going to talk about perspectives on trials of coronary revascularization for stable coronary artery disease.
Thank you very much, and thank you for inviting me. I had the pleasure about 3 years ago, Dr. Pocock invited me to co-author a paper in JACC with him on clinical trials and society's needs, and I have to tell you that I learned more from him writing that paper than I'd learned in the previous 25 years. And he really is a master in helping us to understand biostatistics, because as he really pointed out to me at the time, we don't have the mathematical knowledge to understand the methodology, but we have to learn how to use it. Now, if you look at modern clinical trials, it is said that sorry, I'm having a problem advancing here. The first trial, it was in the 18th century, 12 patients with scurvy, and they had 6 treatments. 2 of them received oranges and apparently got better. 1926, Fisher at Oxford was the first person to randomize, and what is shown here is agricultural research, and that was he looked at the effect of different kinds of manure on potato crops. 1931, first clinical trial with random assignment for pulmonary tuberculosis. 1948, a historical trial from the British Medical Research Council which randomized patients to streptomycin for tuberculosis. And what was interesting about that was streptomycin was in short supply, so if you wanted to have a chance to get streptomycin, you had to go into a trial. Now, one thing about trials is they have their faults, but they are the best way of identifying harm, a randomized trial, and they are the only way, really, to identify the benefit of new treatment. And one example I'll show you here was milrinone. We knew that milrinone increased intracellular cyclic AMP and improved myocardial contractility. And in the 1990s, it was felt that if contractility was depressed, then giving an inotrope would benefit the patient with heart failure. And this mortality trial was done. And what it showed was that milrinone did indeed improve contractility, but it increased mortality by 28%, and in those with class 4 heart failure by 53%. And this taught us that inotropic drugs are proarrhythmic. The other was the CAS trial, a historical trial. We knew in the 1990s that PVCs are bad for you. Every epidemiologic study showed that PVCs are an adverse prognostic factor. And that led to the trial of enconide and flecainide versus placebo, freedom from death or cardiac arrest due to arrhythmia significantly greater in the group treated with antiarrhythmic drugs. And we learned that antiarrhythmic drugs eliminated both PVCs and patients. And this is a classic randomized trial. The logic for suppressing PVCs was very strong, and the supporting evidence was very strong. It was logical, and there was evidence, and we needed a randomized trial to show that it, in fact, was the opposite. But there are limitations of randomized trials and both registry studies, and I'm using here coronary revascularization as an example. Registry studies have selection bias, referral bias, but they're much more relevant to practice at large. Randomized trials have what in this article we called entry bias. And by entry bias, I mean to get into a randomized trial of, say, CABG versus PCI, you have to have clinical equipoise, and you have to feel that the patients are eligible for both forms of therapy. So if you enter a patient into a trial and you feel deep down that they should have PCI or they should go to coronary bypass surgery, it is unethical to randomize that patient. There has to be clinical equipoise. And that's why there's so-called entry bias. And if you look at the trials of revascularization, like the COURAGE trial, for instance, probably only 9% or so, or 10% of all patients who had an angiogram were eligible for randomization. That's not a fault of the trial, it's a fact of life. The majority of people will not be eligible because there is not clinical equipoise. You have a feel of how they should be treated. And the other problem with these trials that take 5 to 7 years to enroll, the prolonged duration of trials introduces a risk of obsolescence. So once the trial is done, there's a new stent on the market or a new form of antithrombotic therapy, and that's the limitations. There's no way you can get around that. And this is in an editorial I wrote about the New York State Registry. Things may not be as they seem. When you look at the survival curves in a registry, you really need to understand the limitations of selection bias. Every database is vulnerable to confounders, every single database. And a multivariable analysis adjusts for these, but it cannot eliminate these. And also, it can only adjust for known and measured confounders. And we have to start off with, as we look at every registry, understand the confounders that are present. Many, many, many examples. Hormone replacement therapy in women, for instance, is one of the classics. Now, here are 2 examples. Drug-eluting stents and late mortality. We knew very early on that drug-eluting stents markedly reduced the rates of restenosis. But in terms of death and MI, at the ESC in September 2006 was the so-called firestorm at the ESC. Drug-eluting stents increased death and MI. And there was a great deal of hysteria. Professor Yusuf said we need to stop training interventional cardiologists, send them into prevention, and so on and so on. Well, let's just go back. Who were the people that got drug-eluting stents in the earlier days? They were sicker patients with diffuse disease, diabetes, small vessels, complex lesions. And this was a study from the Swedish SCAR registry. Then in 2007, 2008, now the same registry in the same journal published from Boston now says Drug-eluting stents reduce death in MI, just 2-3 years later. But 2-3 years later, when drug-eluting stents were widely used, who were the people that got bare metal stents at that time? They were the sicker patients because they couldn't afford to be compliant with clopidogrel, comorbidities, non-cardiac surgery, higher bleeding risk. So not surprising, because they were sicker patients, they looked as though they did worse with bare metal stents than with drug-eluting stents. And the truth is somewhere in between. There's probably no effect of drug-eluting stents on death in MI, at least with the first and second generation stents. Maybe now with the third generation stents, we're starting to see it. But this entire controversy and the financial implications was based upon the confounding effect of different patients entered into registries. And here is a cautionary trail from British Columbia. 141,000 patients prescribed statins for primary prevention, and they were classified as more or less adherent. And then a multivariate analysis compared outcomes with those who were more adherent versus less adherent. And by the way, that was measured by their ability to, by the fact whether or not they filled their prescriptions. And if you were more adherent, you had less motor vehicle accidents, less accidents in the workplace, much more likely to have mammography, colonoscopies, and a much lower likelihood of developing other diseases completely unrelated to the biological effects of statins. So a wonderful example of confounders, people who are compliant, people who enter randomized trials for that matter, are different in many respects from those who are not compliant. And I think a great cautionary tale. Now, one of the great examples came from the Barry trial of PTCA versus bypass surgery. In the Barry trial that was neutral overall, there was, in the diabetic subgroup, a huge difference in mortality, and this analysis was specified by the Data Safety Monitoring Board. Huge. Randomized to PTCA, 34.5% 5-year mortality. Bypass surgery, 19.4%. 87, relative risk 1.87, 87% increase. This kind of difference you don't usually see in trials. Huge. So what are the explanations, and how do we understand it? And by the way, the second part of this was the Barry registry. Now, the registry was a registry of patients who were eligible to be randomized, but for one reason or another, they refused, and they were treated according to the discretion of the physician. So now look at the same diabetics in the registry. In green is bypass surgery, in blue is PTCA. Difference, P 0.7, no difference. So here's a striking example of what happened to patients who were randomized versus those where treatment was selected according to the discretion and judgment of the physician. So how do we explain that? I can understand why bypass surgery is better than PCI for diabetics with multivessel disease for all of these reasons: diffuse progressive disease, chronic total occlusions, increased plaque vulnerability. These patients should be completely revascularized. And as you see in this diagram from New England Journal, PCI is directed at the target lesion or lesions. What it does not address are all of these future culprit lesions, which are the non-obstructive plaques, the endothelial dysfunction, perhaps the microvasculature of diabetics. And with bypass surgery, what you do, and with secondary prevention, you don't just treat the target, you treat the entire vessel, at least in the intermediate period, including the future culprits, which are responsible for perhaps plaque rupture in the future. I won't address the role of microvascular dysfunction, which is a different topic. Now, so for that reason, from a biological standpoint, I can understand why bypass surgery is better than PCI, but that huge difference is still puzzling. And then why no difference in the registry? Now, this is from the Duke database, 1997. This is a registry of bypass surgery and PTCA. And they stratified patients according to the severity of disease, one being one vessel disease, no 95% lesions, no LAD involved. And category 9, three-vessel disease, all 95% lesions and 95% proximal LAD involved. Shown here are the 5-year hazard ratios. Everything to the right, PTCA is better. Everything to the left, bypass surgery is better. And this is 1-vessel, 2-vessel, and then you get into 3-vessel disease. So if you look at this here with the really milder degrees of disease, in fact, PTCA had a better 5-year survival than bypass surgery. But in these patients with 2-vessel disease or modest 2-vessel disease, you can see here that there was really no difference between PTCA and bypass surgery. And these are the characteristics of the non-diabetics in the randomized trials. But in the randomized trial, like Barry, what do the diabetics look like? They looked like this group of patients with severe disease. And in fact, you could have predicted from this registry that those patients, those diabetics with fairly severe disease, really would not do as well with PTCA as with bypass surgery. And what happened in the trials is that we randomized, because it was a randomized trial, both groups of patients. But in the registry, these patients were sent to PTCA, and these patients were sent to bypass surgery. And a rather wonderful example, actually, of the strength of a registry and a limitation of a randomized trial. So the explanation is, I can understand biologically why diabetes, because of its independent effect on disease progression and extent, why these patients would do better with surgery. But the huge difference, the 87% reduction, was also magnified by the process of randomization versus clinical judgment in regard to sicker patients. In other words, we randomized patients to PCI who in practice would have received bypass surgery. A wonderful example, I think, of the differences between registries and randomized trials. We need the rigorous scrutiny of large trials. This is 2 trials of pixelizumab, a complement inhibitor used in an attempt to reduce reperfusion injury after STEMI. The COMET trial, carried out by my great friend Chris Granger, was not that small a trial at 814 patients. The primary endpoint was infarct size. No difference, but look at the huge difference in mortality. Huge. And that led to another trial, a much more definitive trial, 5,745 patients, and this is the result, no difference. And you can see, in fact, the problems that we're having in the stem cell world, where 814 patients would be a large stem cell trial. Most of the stem cell trials are much smaller. And due to funding and other aspects, we are confined at this stage to fairly small trials. But this is the difference between the rigor, or illustrates the rigorous scrutiny of a large versus a small trial. And one has to be very careful of trials where the primary endpoint has not been reached, but subset analyses show other benefits as emphasized by Stuart. Shown here again with magnesium, 1980 to 1990, 7 randomized controlled trials showed a benefit of magnesium in acute myocardial infarction. The Limit 2 trial also showed a benefit, 2,300 patients. Then ISIS 4 with 58,000 patients actually showed a trend in the other direction. And then the definitive MAGIC trial that I worked with Elliot Antman on, a trial of 6,000 patients randomized to IV magnesium versus placebo, absolutely no difference whatsoever. The hard reality of power calculations. If an event rate is only 20% and the magnitude of the benefit is 15%, then the sample size required is approximately 25,000 patients in each arm, depending on whether you want an alpha of 0.8 or 0.9. And this has a huge effect on the cost of a trial, and funding is difficult. If the event rate is only 10% and the magnitude of the benefit is only still 15%, then the sample size required is 5,000 patients in each arm. And that's the reality of power calculations. Now, in trials of myocardial infarction, and also in the stem cell world, what has really made these trials very difficult is LV function after MI and late event rates are decreasing. So we were basing trials on an event rate of 10%, and we're now getting event rates of 4%. So what we're seeing in an era of improved outcomes is increasing difficulty in funding and the requirement for very large trials. From my colleague Rajiv Gulati, this is an important, I think, study from the Mayo Clinic of 5-year mortality after PCI. 1991 to 1996, cardiac mortality dominates as the major cause of death. At 5 years, probably 10% cardiac death and about 6% non-cardiac. The next 5-year period, the cardiac and non-cardiac mortality are equivalent. And now 2003 to 2008, as we deal with older, sicker patients and better PCI technologies, the 5-year mortality is now going to be dominated by non-cardiac mortality. And that has a huge effect on trials. You know, 30-day mortality, that's fine. I mean, that's cardiac. But when you start to look at late mortality, it's dominated by non-cardiac mortality. And that has a huge effect on what endpoints you use to determine the result of the trial. And so if you just use all-cause mortality, you may not show a benefit. You have to look at cardiac and non-cardiac mortality separately, and it complicates matters. So this leads to surrogate endpoints and quality of life endpoints, such as New York Heart Class, 6-minute walk, etc. We use this in the stem cell trials. The problem is all of these are vulnerable to the placebo. And then it brings into account blinding issues and the critical importance of sham procedures. I do not agree with the findings of the Orbiter trial. I agree totally with Dr. Pocock. But I do agree that it's important to have sham procedures, and I think they deserve credit for that. And this was shown in this analysis from the paper with Stuart Pocock of Simplicity Hypertension 3. The first renal denervation trial, no control group, 25-millimeter drop in blood pressure. The second trial, Simplicity 2, denervation with an unblinded control, hugely positive. And then Simplicity 3, where you compare denervation with a sham denervation procedure. And what you see is denervation still reduces blood pressure, but by much less. But if you look at the sham control, there's also a significant reduction in blood pressure. We could talk all day about the differences between these trials, and but I do think that one of the major impacts of major reasons for the difference between Simplicity 3 and the other trials is the sham control. And here's a great example of the placebo effect. This is 4 trials of cardiac pacing for vasovagal syncope. And remember, vasovagal syncope involves the brain. And if you look at these 4 trials, that this is favors treatment with a pacemaker, and this is medical therapy to the right of the line, you'll see that the relative risk reduction is 0.08. That's a 92% reduction in recurrent syncope. Totally implausible. Confidence limits very low, 0.03 to 0.24. But then what they did was 2 trials where they randomized patients. They all got a pacemaker, but they were randomized to the pacemaker being actively programmed versus inactive. Double-blind active pacemaker versus sensing only, but pacing off. And these 2 trials now show no difference, but in fact, a trend towards the opposite, with a 1.49 odds ratio. Very, very, I think, striking example of the effect of blinding in a placebo. Mark Twain, one of the great American authors, wrote a lot about the placebo, interestingly enough, in the 1800s. And here is a story about him. He was convinced that he could only sleep in well-ventilated rooms. Finding himself in a small hotel room with a window that was stuck shut, he tried in vain to fall asleep. It was a hot Midwestern night. He couldn't bear it any longer. He reached under his bed, picked up a shoe, heaved it at the window. He heard the crash of glass, immediately felt better, quickly fell asleep. Woke up the next morning very refreshed to find that he'd missed the window and he'd shattered a mirror instead. And if that isn't placebo, and he actually said, the first man is born with vulnerability to placebo and the last man will still have it. Now, this is something I learned from Stuart about composite endpoints. Their convenience, statistical powers increased, frequency of events. The more events you have, the less sample size, the effect on costs. But as pointed out here, a danger of oversimplifying the evidence by putting too much emphasis on the composite. And here is an example from the syntax trial, and let's just go through this carefully. The syntax trial at 5 years, or 1 year, but also at 5 years, showed a significant difference in composite MACE. 12.1 for cabbage, taxus stents 17.8, p equals 0.002. But as he's always made a point, every time you see a composite event, you need to look at the individual components. So let's look at death, MI, and stroke. Death, no difference. MI, no difference. Stroke actually higher with bypass surgery. So the driver for MACE in this study was repeat revascularization. So if you judge this study on the top line here, which is MACE, you may come from a very different conclusion than if you look at the other endpoints, which to me show a higher rate of repeat revascularization, but with cabbage, a higher rate of stroke. So it really changes the conclusions. And this is close to where I live in Jackson Hole. If I can read this sign for you, going beyond this point may result in death and or loss of skiing privileges. So I think, even given the cost of lift tickets in Jackson Hole, I don't think loss of skiing privileges is quite equivalent to death in this composite endpoint. Be careful about multiple subset analyses. This is one of the great studies, I think, published, the ISIS-2 trial of aspirin and astrology. Overall, a benefit from aspirin, but if you Libra and Gemini, no benefit. Other birth signs, a significant benefit. And this is what happens when you have 50,000 patients in a trial, and you start breaking them down into all kinds of different subsets that really may not have any biological reason for there to be a difference in the treatments. And Stuart has pointed out, this is an extreme example, but beware of those trials that go fishing for a subset that might benefit. And here's another great example, the Plato trial of ticagrelor. The trial was not powered to answer the question by region. It was powered to answer the question for the group as a whole. But if you look at the data, there was a hazard ratio in North America of 1.25 that was almost significant, suggesting that clopidogrel was better than ticagrelor, whereas in the other countries there was a trend towards the benefit for ticagrelor, and there was overall, if you look at the 0.05 p-value interaction. So we left with the fact that in this overall positive trial in North America, ticagrelor does worse, and we do not know whether this is statistical noise or related to the dose of aspirin that was used. We just don't know, and it required another trial. And this is the hazard of a subset analysis that's not really predefined. And finally, occasionally there are trials where there is a real benefit to a subset analysis. I was on the Data Safety Monitoring Board of the TopCat trial of aldactone. And in fact, what went on in that trial is now published by Dr. Mike Bristow and a number of us in JACC Translational Research. Very early on, we noticed a problem between the patients in the Americas and those in Russia and Georgia. And we alerted the steering committee to this problem. They looked different, their baseline characteristics were different, and as we subsequently found out, the outcome of aldosterone antagonism in Russia and Georgia, there was a much lower event rate, much lower rate of cardiovascular death, and overall the trial was neutral, but in the Americas, there was it was a positive, modestly positive trial of CV death, cardiac arrest, and heart failure hospitalization. There are a number of reasons for this, some of which we could not put in the paper, but I think it was financially very attractive to enroll patients in this part of the world, and it does turn out that these were different patients. I don't think they all had HFpEF. I think many of them had coronary disease. There's also strong evidence that they weren't taking the drug, and subsequently there's been an analysis of blood samples that have shown the dose of aldactone was far lower in Russia and Georgia. So I don't think they had HFpEF, and I don't think they were taking the drug. And this is a situation where a subset analysis was helpful. So to conclude, I think Dr. Pocock said a p-value is no substitute for a brain. Find out who set up this experiment. It seems that half of the patients were given a placebo and the other half were given a different placebo. So I think the design of a trial is critical, as well as how we analyze the data. Thank you very much.
So thank you, Bernard. Thank you both for being stick to the time. So we have like 3 or 4 minutes for a brief discussion. Before we start, I invite the audience if there is any question. I think we have Esteban has a question. Do we have a microphone? I think Esteban.
Yes, both of you, Stuart and Bernard, talk about against the Orbita trial. And do you think we need some procedure in a randomized trial of intervention? For example, now the ischemia trial has changed the primary endpoint. Previously was death and MI, and now is rehospitalization, revascularization, and things like that. So do you think that we need some procedure as a control group in interventional cardiology?
In a word, yes, I think we do, because when it showed renal denervation was naively positive in its conclusions until they did a sham procedure trial. I think the FDA actively encouraged that kind of trial in the device world. And so I think with PCI, I think it's a very interesting development. And I think Orbiter is not the end of the story. I suspect there will be sequel, better designed, hopefully larger trials, which will explore with a sham procedure. So I think they do have a purpose.
Yeah, I suppose because of this trial, which I think has many flaws. I think it is completely underpowered. If you look at the medical arm, the way they were treated was completely ridiculous by most standards. I mean, they had a conversation with their cardiologist 4 days a week to adjust the dose of their drugs. I don't think you can assess at 6 weeks the effects of either. I think the placebo effect is present early on. I think it's ridiculous at 6 weeks. And frankly, I did hear about the trial a year before when they presented it to me, and my answer was, why are you even bothering to do it? Because I know what the result is. It's going to be neutral. So, and I think if you look at the differences graphically, as was pointed out, the trends are very clearly in trend in favor of PCI. And then the exercise echo showed a reduction in regional wall motion abnormalities. So there's a commentary coming out from Deepak Bhatt and myself in Circulation, and Steve Windecker and Gabriel Steg, the 4 of us. We were asked to provide a commentary, and our answer is, well, it raises the question about perhaps we should have done a placebo-controlled trial 25 years ago. Maybe we'll have to do one now. I'm still a bit undecided. I still think the bulk of the evidence is hugely in favor of PCI. And the other reason why I think it is because PCI is so effective in the acute coronary syndromes. The other point that I would like to make about the recent article about changing the endpoint in the ischemia trial, I strongly agree with Dr. Francis's group about that article. I also strongly resent the fact that the article appeared in Forbes magazine the next day. And thirdly, I've been involved in trials where we've changed endpoints. The SAVE trial was one example, and it is perfectly appropriate if it is done, as Stuart pointed out earlier today, honorably. If you find, without knowing the results of the trial, if you find that the endpoints, there are far fewer events than you expected, and the steering committee meets with the Data Safety Monitoring Board, it is perfectly appropriate to add additional endpoints. And we did that in the SAVE trial of captopril and in other trials. And in any event, as he's pointed out, you have to look at the individual endpoints anyway and make up your own mind. So I think it was a storm in a teacup, and to then read that, you know, the cardiology world is devastated by this, quote, improper behavior by the NIH is absolutely, it doesn't do anybody any good. And sure, they can add extra endpoints. You know, you can make death in a MI and an earthquake in California an endpoint. But when you look at the results, you're not going to say, if it's positive, it's because it causes more earthquakes. So I resent that article, and I think it was not appropriate.
Alex? Yeah.
Yes, thank you both. It was a great session. But I have a question about negative trials here. And so I'm thinking about some recent trials in acute heart failure with very promising drugs that had some interesting investigational results. And in the end, these huge trials, a tremendous effort of the industry, of all the research teams, and they came out negative. And in the end, it's a negative trial of a promising drug, but we're left in our everyday clinical practice with older drugs that have no evidence at all in favor of their use. So I would just like to hear your opinion on this.
I think it depends whether the trial was large enough to be convincingly negative, i.e. truly was a neutral trial or even trending in the direction of harm, or whether it was like the VEST trial, perhaps an inconclusive trial because the amount of data wasn't enough to say whether there's a real positive there. So I think with Greg Stone, I wrote an article in the New England Journal about the primary endpoint fails, what next? That's not the end of the story. And sometimes you rejig what the next trial should be with the same drug. Like we were having beta blocker trials in heart failure, the original CIBIS trial of bisoprolol was negative. It didn't reach a conclusion, but they said, hey, there's something in this. And therefore, we're going to do a larger trial, which in the end had to stop early because it was so positive. So some negatives are a motivation to the next trial. Others are, this isn't working, let's move on and do something more useful. And it's often tricky to separate the two, but that's where the debate lies, I think.
Stuart, why was CIBIS negative and the others positive?
The original CIBIS, it just wasn't large enough. They used to be comfortable to do a trial with 600 patients in heart failure, and now we know that's too much uncertainty and you need more.
Okay, so this is a great discussion, but unfortunately we have to stop just to let the next come here. So thank you both for your wonderful speaks, and also thanks to the audience for your participation.